Now I can give the floor to Cristina and John, and we can get started.
So thanks to everybody for being here in today's Legends of Surgery. Today is for me a great honor to introduce Dr. Nancy Ascher. Nancy Ascher is a very well-known surgeon in the field of liver transplantation. I would like just to introduce a brief background of her. She studied in the University of Michigan. She completed her surgery residency in Minnesota. And then she was recruited in 1988 by the UCSF Department of Surgery to build a liver transplantation program. And then she was the first woman who performed a liver transplant in the world, I have to say, isn't it, Dr. Ascher? So I think it's a very huge honor for me to introduce her. In 1991, she was appointed Chief of Transplantation and thereafter Vice Chair of the UCSF Department of Surgery. And in 1999 was appointed Department Chair. She always defended gender equality and has a distinguished career of public service that includes Presidential Task Force on Organ Transplantation and the Surgeon General's Task Force on increasing donor organs. She also served as the chair of the Advisory Committee on Organ Transplantation for the Secretary of Health and Human Services, was a ASTS president, counselor of ILTS, president of the Transplant Society. She received a lot of honors and the Thomas Starr Prize, so multiple awards, research, and publications. So just it's a great honor to having you, Dr. Ascher, and the floor is yours. So hope everybody will join the Dr. Ascher's talk.
Can you see my talk now?
Yeah, but not yet, Dr. Ascher.
Okay. And now?
Perfect.
Okay. So thank you so much, Cristina. That was a very kind invitation, a very kind introduction, and I'm delighted to be here to share some of my experience with you. The reason I called this, If You Meet the Buddha in the Road, Kill Her, comes from a book of that title, except that it said kill him. But the idea here is that it's important for you to not assume that your teachers know everything. You are going to gain experience from your teachers, but you also are going to leave yourself open to ideas and to development on your own. And that's really, really, really important. So I'm happy to share my experiences with you, but I don't want you to think that's end all and be all. You've got to figure it out pretty much for yourself. As Cristina said, I've had a number of interesting roles, and I certainly have had my share of honors. Right now, I'm professor of surgery, and that's what I love doing because I get to do liver transplants and kidney transplants and live donor operations for live donor transplants. So I feel like I've come full circle. That's where I started, and that's where I'm back. And I'm still totally excited about what I do day to day. So I can't advance my slide. I think someone's going to have to do it for me. Oh, I guess I can. Sorry.
Yeah.
So I come from Detroit, Michigan, and I know that you are all very sophisticated Europeans, but I just want to remind you of the map of the US up here. And here's where I started, and here's where I've ended up. I'm obviously moving across the country, but I started in Detroit. And for those of you who don't know what Detroit is all about, you probably know that the Ford Motor Company and automobiles were what was defined Detroit for many, many, many years. Some of you may recognize Motown, which was a style of music that was very popular. And I know about that as well. And when Motown music happens, I have to get up and dance. I want to show you this, though. This is a mural from the Detroit Art Institute, where I used to go every week with my mom and my siblings. And this is a Diego Rivera mural. And those of you who know Diego Rivera know that he cared a lot about the workers. And so this mural that he painted was to honor and to celebrate the workers in the Detroit automotive industry. Here's Henry Ford here. Henry Ford was so upset about this mural where he was depicted as this little figure right here that he refused to pay for it. When I was a little girl, what turned me on about this mural was this depiction of Mother Earth in a bunch of different guises in terms of races, but all women and so strong. And that really impressed me when I was little. Fast forward, as Cristina said, I went to the University of Michigan. It's a state school, but it's an outstanding state school. And that's where I really learned about kidney transplantation. I went there for both undergraduate and medical school. And at the time at the University of Michigan, kidney transplant was what they were doing. And I thought it was so exciting to think about the fact that you could take a person in renal failure and bring them back toward normal. After that, though, I went to the place where transplant was happening at the time, and that was the University of Minnesota, led by Dr. Johnn, whose name you might know, who recently, just a couple of years ago, died, but was an incredible leader in transplantation. Fritz Bach, who was a basic scientist, and Richard Simmons, who was a clinician scientist. So these were my role models and my mentors at the time. And you can see they're all men, of course, because that's pretty much all that was there at the time. When I finished the University of Minnesota, the world was open to me. I was offered a job there, but I was also offered a job by this guy, Thomas Starzl, who was the father of liver transplant. So he said, why don't you come and work with us in Pittsburgh? And of course, that was very appealing to me, but I decided to stay at Minnesota. Having said that, what really turned me on was this organ, the liver. And this is a photograph of a cirrhotic liver. This is a photograph done by a photographer from National Geographic. And this is us putting in a normal liver. And you can see the difference between that cirrhotic liver here and this beautiful transplanted liver here. So I did my first kidney transplant when I was 27 years old, and my first liver transplant when I was 32 years old. So I have been in this field for many years, and I feel like this is my home. I know this, I know the anatomy and these organs so well. I feel completely comfortable, and I hope you do too in the fields that you've chosen. So I went in 1988, as Cristina said, to the University of California, San Francisco. And I went there to begin the liver transplant program there. Having started the liver transplant program at the University of Minnesota, by then I knew that I could do that. And I rose through the ranks to lead the entire transplant service, but also to become the chair of the Department of Surgery in 1999, a position that I held for 17 years. So I want to tell you some of the things we did and some of our accomplishments to give you a sense of how I ran my career. So one of the first things we did was to actually define what liver transplant rejection was about. No one really understood it. Everyone thought that the liver was a privileged organ, and it is. However, we began doing protocol biopsies at weekly intervals after transplantation, and were able to define actually what liver transplant rejection looks like. And you can see here the sea of lymphocytes that are surrounding the bile duct epithelium here. That's one of the hallmarks of liver transplant rejection. Also, there's a central venulitis that's associated with liver transplant rejection. And what we found was that the bile duct cells and the endothelial cells had a lot of class 1 and class 2 antigens on them. The hepatocytes, in contrast, only had class 1 antigen. So the bile ducts and the central veins were the targets of the immune response. And this helped us a lot, both in terms of how to make the diagnosis, because don't forget, we had recurrent hepatitis, we had many other causes of abnormal liver function tests, but it also helped us define the treatment for liver transplant rejection. We also were one of the first groups to advocate the use of liver transplant for fulminant hepatic failure. The group from the UK also was quite instrumental in this. But what fulminant liver failure is, a normal person who suddenly develops liver failure. And these people, although they're very gravely ill with MELDs in the 40 to 45 range, can greatly benefit from liver transplant. So we were the first group to really advocate for doing prompt liver transplant in this group of patients. And we convinced the people in the United States to make these patients with fulminant liver failure, at the highest priority for getting an organ. So we were able to serve these patients quickly, and that was a great advance. We were also central to the transplantation of patients with HIV disease. You all know that with the heart era, patients lived a lot longer who had HIV disease, but when they lived longer, we found that they were dying of end-stage renal disease, end-stage liver disease, and heart failure, diseases for which transplant is appropriate. Now, in the early days, we were totally frightened that patients with HIV, once given immunosuppression, would completely melt. But it turns out that, in fact, they didn't melt. They actually had an enhanced reaction to the grafts. So they had an increased rate of rejection, not decreased rejection. And this indicated to us, and has been subsequently determined to be correct with basic science studies, that these patients have dysregulated immune system. So we found that we actually could do transplant in these patients, that in fact, these patients had more rejection than regular patients without HIV disease. And we found that there were certain agents that were good for these patients and other agents that were not so good for these patients. So that was an advance that I'm proud to have been part of. This may relate to more people in the audience, you guys being young oncologic surgeons. You all recognize the cirrhotic liver shown here in the CT scan, pulled away from the abdominal wall, but you note here this, lesion consistent with hepatocellular carcinoma. And so we were one of the first groups to define what the criteria should be for transplanting patients with hepatocellular carcinoma. Now, you know that the field of oncologic transplantation is totally taken off, and we are transplanting patients who have a variety of different kinds of cancers more and more often. And of course, that's what your generation will carry through with. So what we did was, at the time that we started looking at this work, there was the Milan criteria, which was defined by a group in Milan, Dr. Mascaro, 1 lesion less than 5 centimeters, or 2 to 3 lesions, none greater than 3 centimeters. But we were able to expand that criteria, called it the UCSF criteria. So slightly larger single lesion and more tumor burden with multiple lesions. Since then, of course, the field has gone further. We now can transplant many patients with much larger tumors, or many more tumors than we did early on. We also asked the question as to whether or not, if we had a large lesion greater than either UCSF or Milan, could we downstage that lesion with local regional therapy? What would happen to those patients? So we set up a criteria, a study to look at local regional therapy with the attempt to downstage patients to get them within the Milan size and to see how they would do. And what we found was that those patients for whom we could do downstaging had outstanding 5-year survival with very low recurrence and a 56% 5-year intention to treat survival. So this was, again, another advance. Since then, the field has gone even further. This is the survival of patients who were not downstaged versus those who were downstaged to get to Milan criteria. So you can see that patients who undergo downstaging really do wonderful after transplantation. And of course, you will recognize this drawing of the anatomy of the liver by Cunard, the famous French anatomist, who taught us that the different areas, the neighborhoods of the liver, the arrondissements, if you will, from France, from Paris, have their own separate inflow, portal vein inflow, their own separate hepatic vein outflow. And this enabled us to do both large liver resections, you all know, and anatomical resections or segmental resections, but also let us do pared down liver transplants and living related liver transplants, which is another part of the field that I have enjoyed so much. So this is a patient for whom we're about to do a right hepatectomy for live donor liver transplant. And you can see the two lobes of the liver. We can use either lobe, actually, depending on the size of the recipient and the specific anatomy of the liver segment. This is the same patient for whom the right lobe has been removed, and you can see the remnant left lobe, which grows back within a couple weeks after donation, which is incredibly cool and allows us to do it. The fact that the liver regenerates allows us to do this aggressive therapy, and of course allows you to do the resections that you're doing for liver and that we do for liver as well. This is data showing that both either the left or the right lobe results in the same recipient outcome, and that's what we're showing here with excellent long-term, this is 10-year long-term results in these patients. What's interesting, though, is the pattern of regeneration. So this is a CT scan of a patient who underwent a right hepatic lobectomy for live donor liver transplant. So our resection line would be just about here. And then we allow the colon to fill the space. But this is what this patient looks like 6 months after donation. The liver actually has resumed its entire size. If you were to do the volumetrics here versus here, and you can't, of course, without seeing the whole CT scan, but you'll note that the liver grows in a different direction. So it grows onto the right side, kind of pushing on the stomach, and these patients obviously have early satiety. You can see that the spleen is slightly bigger, so we do see a drop in the platelet count in these patients, but no long-term bad sequela for these patients who donate either their right or their left lobe. Perhaps besides doing the first transplant, liver transplant as a woman, my greatest contribution has been what we have done for women in surgery. And the next slide shows you the basic problem where I think this is true in Europe as well as the United States, where 50% of the medical school class are women, but as you go up the academic ladder, there are more and more men who are in positions of authority. So when I was a department chair, there were 2 other women department chairs of departments of surgery in the United States. So despite the nearly equal male and female medical students that we see, by the time we get to real positions of authority, the women seem to fall off. And we need to understand why that is, whether it's because women don't want these jobs or whether or not women are being discriminated against. And of course, that's, it doesn't just apply to women, it applies to many disenfranchised groups who have not really been appreciated in the past. So this is an old slide, but shows you, again, regardless of the field of surgery, although the medical students are 50%, as you go up the ladder, there's fewer and fewer positions of authority that are assumed by women. So I was very fortunate because I went up the ranks pretty quickly and I got to be chair. And of course, when you do that, you've got to pay back and you've got to think about the other women who are following you. But I want to show you some of the kind of what I think are the basis for this unfortunate disparity. So this is a very famous study by Dr. Jo Handelsman. This is a woman. And what she did, and she and her colleagues did, is they made a fake student. They made the CV of a fake student who was applying for a job in a lab, in a science lab for a clinical, for a clinician who also had a basic science lab. So they described the male and female student exactly the same. They had the same attributes, the same amount of training. Everything was the same except for the name. And for the male student, the name was obviously a male's name, and the female student, it was a female's name. But they had the same qualifications. Despite that, the people who evaluated the CV, and they didn't know it was a fake CV, thought that the male student was more competent, thought that the male student was a better hire, and thought that the male student would be easier to mentor than the female student. Even though first of all, the CVs were made up, the CVs were the same except for the gender of the person applying. In addition, these people who did the evaluation, these medical doctors who did the evaluation, thought that the male student should be paid more than the female student. Now, this was both men faculty and women faculty. So I can't just blame the men faculty. These are also women who are judging women more harshly. So before we point our fingers at our male colleagues, we better look at ourselves and make sure that we are treating one another fairly. This is another even probably more interesting study. So this woman, Heather Sarsons, looked at data through the U.S. database. This is hospital-based data with referrals and admissions. And what she found was that when a male surgeon or a female surgeon has an unexpected death of a patient, subsequent referrals to the male surgeon doesn't really change, but subsequent referrals to female surgeons go down. Now, the referring doctors were both men and women. So again, we can't just blame our male colleagues for discriminating against us. In fact, our female colleagues are feeling the same way. Also noteworthy is if we have a great outcome, either a male surgeon or a female surgeon has a great outcome, an unexpected survival where we congratulate ourselves, the male surgeons get more referrals. They both get more referrals, but the male surgeons get more referrals than the female surgeon. So we've got some work to do. And I think we can't just blame our male colleagues. We've got to think about what this means for ourselves as well. Perhaps this latent bias can be explained by a group from the University of Warwick, and they were studying non-first English-speaking immigrants to the UK, and they asked this group of participants, both men and women, to draw a picture. Don't describe, but draw a picture of a leader. And so what they found was 90% of the drawings, over 90% of the drawings, 93% of the drawings were of a man. So when we think about what does it mean to be a leader, what does a leader look like? This is what was drawn. This is an example of what was drawn by both the men and the women. Here's some more drawings. He probably you would recognize as a leader, and I would agree with this, but you can see that the gender of the people that were drawn tend to be of male, not female. So we've got work to do. We really have to celebrate one another to make sure that we are being completely fair. This is my own report card when I was chair of the Department of Surgery. This is the percentage of residents, and we've got to, this is surgery up here, and we've got to compare ourselves to the ACGME benchmark. So this is where the ACGME benchmark was during the years that I was chair, with about 35% of the residents in the US in surgery being women. But by the time I was done being chair, we were up to 50%. And I think at many of your programs, 50% of your residents are women. But more important, this is important, but I think equally important is what about women faculty? It's not enough to have women colleagues as residents. We've got to look to see who our role models are. And this is my report card when I was chair for our female faculty. Again, we have to look at the double AMC benchmark. So you have to look at other academic centers across the country to see what the standard percentage of women faculty are. And you can see that at the time that I was chair, it was about 22% across the country, and ours was 30%, 35% by the time I was done. It was 40% of our faculty were women. So that was my contribution, and I think it makes a difference for us to see people with whom we're comfortable, who we feel represent us in positions of authority. Now, more recently, what I've been most interested in is what's going on globally with transplantation. And there's no question that transplantation has been hailed as one of the major scientific accomplishments in the 20th century, but how this fits into the big picture of health and practice, we have to justify, we have to ask ourselves. You know, transplant for many people is seen as very high end and not really based in reality, and certainly not based in reality for third world communities, which isn't really true. So the current issues in transplantation are an inadequate number of donor organs, the quality of the donor organs, complications of immunosuppression, the workforce, the best practice, and exploitation of live donors. And I'll talk a little bit about that in a moment. This is the amount of this reflects the amount of transplants that's done. This was from 2019. The registry is kept in Spain. It's called the GODT, and it's the Global Observatory. But you can see that, relatively speaking, relative to the number of people in the world, transplantation is kind of a little niche practice, with 160 solid organ transplants performed in that year. It's up to about 170 at the present time. So transplants are relatively rare in the bigger scheme of things. What's interesting is that it represents less than 10% of what we actually need. And I'm going to show you more data about that. So I don't know how many of you have ever had a chance to go to the World Health Assembly, but really, as young surgeons, you need to understand what's going on. I think it would be helpful if you understood what was going on in the world. And at the World Health Assembly, the Minister of Health of every single country gets up and talks about what their country plans to invest in and what they plan to look at. The World Health Assembly also develops lofty goals for health and service for the world. And so these are the goals that were passed in 2015 to be achieved theoretically by 2030. And of course, we are nowhere near achieving this, but the most important goal from what we're discussing at the moment is the notion of good health and well-being, with the idea that universal health care is the ideal for patients throughout the world. But what the World Health Assembly has asked for is a decrease by 30% of avoidable premature deaths throughout the world. So to think about that, we have to understand what causes death. Why are people dying prematurely? And despite the fact that this isn't your day-to-day interest or your day-to-day practice, I think it's really useful for you to think about it, particularly because you're interested in cancer. So you've got to think about this. So when you look at the causes of death in the world and compare year 2000 to year 2016, you can see that increasingly, particularly in middle income and high income countries, that infectious disease, shown here in red, is decreasing, and what's increasing is non-communicable diseases. So this is disease of the heart, disease of the kidney, disease of the lungs, disease of the liver. These are diseases that can be treated with transplantation. Now, I recognize that we are just coming out of a giant global epidemic. So this data for 2019 through 2021 will be different given COVID. But once we get back to steady state, it's non-communicable diseases that are important. And these diseases are treated potentially with transplantation or with aggressive cancer care. So this is the estimate of deaths in individuals between 30 and 70 over 100,000 population. The reason we pick 30 to 70 is these are potentially preventable deaths. These are considered premature deaths if you die before 70, depending on what the life expectancy is in your country. So the most common is ischemic heart disease, lung, diabetes causing kidney disease itself, and liver cancer. So these are important causes of diseases. Another way to look at the diseases, you don't have to just die from them, you can suffer from them. For example, let's look at the prevalence of chronic kidney disease. This ranges between 5% in Norway and the Netherlands, up to 24%, 1/4 of the population in Saudi Arabia. So these people could benefit from renal replacement. The US, it's 14%. And this relates to genetics. It also relates to local mores and culture and diet and obesity and hypertension. If we look at chronic liver disease, this is information from both the world as well as China. But you can see that hepatitis B infection throughout the world involves 2 billion people. Hepatitis B surface antigen positivity, of course, most common in China, but also common throughout the rest of the world. Hepatitis C, alcoholic liver disease, NAFLD, the most recent epidemic of illness in the cause of liver disease. So you can see that there are so many people who are suffering from chronic liver disease and could benefit from transplantation. So if you actually, as remember I told you about 160,000 solid organ transplants done every year, these are the estimates of the people who could benefit from transplant. For kidney, more than 10 million. For liver, somewhere between 2.5 and 5 million. For heart, up to 18 million people who could benefit. So the numbers are incredible, and that's why we're looking to transplant as well as alternatives. One of the problems in looking at burden of disease in this way, and of course, those of you who are interested in doing it, there's a huge project looking at burden of disease with cancer. Dr. Elbawi works for the WHO, and if you're interested, you should really contact him. But the problem is lack of collection of death data in certain countries. There's variability in the quality of death data. There's unavailable information in many countries, and we really need to figure out at a country level the specific data regarding the number of people who die with end-stage organ failure or could benefit from organ transplant. So this ties into what the responsibility of a country is. So I have been fortunate to be able to advise many countries as to their responsibility as to national self-sufficiency. And what this means is that each country understands how many patients who have end-stage organ disease and could require either support with dialysis or with transplantation or other methods of treatment, that the country thinks about meeting the need with adequate health providers, both for organ failure, but also, this is not just surgeons, it's also physicians, nursing, hospital resources, that the countries think about meeting the transplant need with both live donor and deceased donor sources and the infrastructure to support this. And the country meets the needs to keep track of patients with end-stage organ disease so that we have a registry, so we actually know what's going on. So these are some of the things that the countries can do. And I've spent a lot of time talking with ministers of health to try to get them to think about these things that would enhance organ donation and transplantation in different countries. Maybe the most important is to make sure that there isn't unethical transplant going on, such as paid donation or trafficking in persons or how we approach foreigners. Recently, in 2021, we had a meeting that was co-sponsored by the World Health Organization and the Pontifical Academy, which is the group in the Vatican that actually advises the Pope as to healthcare and healthcare needs and advances. And these are the goals of the meeting that we had. We brought together people from 83 countries to discuss these issues. Now, there's no question that when in something like kidney disease, hemodialysis or peritoneal dialysis or kidney transplantation, this is the tip of the iceberg. In fact, there are many more thousands of patients who have renal insufficiency, and we have to think about how to treat those patients before they get to end-stage renal disease. And so those are the kinds of things that we talked about at this meeting. This is interesting data from around the world, and you can see that in most countries, kidney transplantation is not the primary way to care for patients with end-stage kidney disease. It's either hemodialysis or peritoneal dialysis. So for example, in the United States, shown here, the majority of patients with end-stage renal disease are not treated with transplantation. This is despite the fact that in nearly 2 million patients in over 100 cohort studies, the International Society of Nephrology has demonstrated that patients who undergo kidney transplant versus hemodialysis or peritoneal dialysis have improved survival and decreased risk of cardiovascular events. They also have improved quality of life. So one of the things that came out at this meeting was the fact that kidney transplant is cost effective. Kidney transplant gives better outcome. Kidney transplant gives better lifestyle, but the majority of people in the United States cannot avail themselves to it. People throughout the world can't avail themselves to it. And it's not just better quality of life and better outcome. It's also the incredible burden on our environment when we do hemodialysis. In Europe, hemodialysis costs between 70 and 80,000 euros per year. It's estimated that the number of people who are undergoing renal replacement therapy will be over 5 million by 2030. And the dialysis for 2 million people is incredibly wasteful in terms of water and plastic waste. So as we think about our environment, as well as thinking about our patients, we've got to come up with a replacement for hemodialysis and peritoneal dialysis. Now, we really don't talk about cost benefit when we talk about liver transplant, because really the alternative to transplant frequently is death. So we don't have a comparator there. Now, there has been one paper that's looked at cost effectiveness of liver transplantation, and that's in patients with colorectal metastases confined to the liver. And this group found that, in fact, in this group of patients, transplantation was cost effective. So the results of this workshop really focused on operational guidance for ethically sound, living and feasible deceased donor transplantation. It also called for international cooperation. So this has been an area that I've been very much interested in, and it's been really wonderful as an area of research. Finally, I wanted to say just a couple words about donor exploitation. In the early 2000s, there was kind of a division in the world between a recipient who was generally a male, who with a relatively high income, perhaps coming from Israel, perhaps coming from the United States, Canada, or Australia, and then going to one of these places where the typical donor was a younger male with a much lower income. So there was marked disparity in terms of the economic condition between the donor and recipient, but this was really organ trafficking, unethical exploitation of humans for transplantation. And this has been an area of my interest as well. More recently, the way people move around is quite fluid, and they go from wealthy countries to less wealthy countries and then back again, depending on their wealth. And you can see the fluidity throughout the world with patients traveling for transplant, some of which is ethical and some of which is not ethical. We examined what was going on in the United States because we found that people were coming from certain countries to get deceased donor transplants here. And what we found was like a bimodal distribution. We found that poor people who were coming from South and Central America were coming to the United States and were getting kidney transplants. These tended to be laborers and were getting kidney transplants because their kidneys failed as they worked in the grape fields of California. We also found that there were many well-to-do patients who were coming for liver or kidney transplant. And these patients, of course, were in the United States specifically to get transplants, not because they were working here. We use this data to educate UNOS, our organ procurement and distribution system in the United States, to educate them about this potential problem. And you can say that these numbers are not great, but if you're one of the other patients who are waiting for a kidney transplant, and your kidney or your liver has gone to a person from a rich country, that may not be perceived as being fair, as being equitable. So I'm going to stop there. I have been delighted to address you. This is the winged victory, of course, reminds us that if you have a vision, if you have something that you're passionate about and you have a vision about, then you can get other people to go with you, to follow you. And I want to leave it with that. Thank you all for your attention. I'd be happy to answer any questions that you have. Thanks.
Thanks, Dr. Ascher. It was a great message. I have to say, thanks for your great presentation. I don't know if there's one in the chat. I just introduced John Henry as my co-chair, that I didn't do it before. John, I don't know if you want to ask any questions to Dr. Ascher.
Hi, John.
Hello, can you hear me?
Yes.
Can you hear me?
Yeah, perfectly, John.
Thank you very much, Dr. Ascher, for your wonderful presentation. I have to admit that I also saw the documentary in Netflix. I enjoyed it as much as your presentation today. I wanted to know, nowadays we are always talking in surgical congresses about empowering women. And I think this is important, but I was wondering, what is your opinion about this? Because obviously your experience as a surgeon, when you started your training years ago, was completely different from what we have today. So I wanted to ask you, what do you think about these activities or conferences we are having in surgical congresses? And how do you think, or what do you think is the best way to help women in surgery?
So I'm not actually interested in empowering women if they can't do the work. And maybe that's a very unpopular thing to say. I need, you know me, I'm a maniac. I need everybody to try harder. I need everybody to work harder. I need, the women that we hired, the women that we trained, we didn't hire them because they were women. We hired them because they were qualified and they could do the job, and they did the job. It's the same thing as the men. I mean, the real problem is that surgery is so difficult for everybody. And there's so many demands on you, and they're asking you to give up your, parts of your lives and commit yourself to the patients and not get paid well and just to do it. And we've got to, and people are getting burned out and people are dissatisfied. And we have to change the field for everybody, not just women, but for men too. Men want to be with their families. Men want to have more to their life than just their profession. I think we all want that. We all want satisfaction. We all want to be appreciated. We all want to do a good job. So I think we've got to kind of figure out how to make this happen for everybody, not just women. We do have to give women, we have to give people who can do the job an opportunity to do the job. And you heard me say people. That's what I think. So maybe that's unpopular. I've been really lucky because the women, the people we chose to do these jobs could do the jobs. We gave them support to do them, but then they did the jobs. And that's what's important in this life.
I have a question, Dr. Ascher, because, or maybe I had prepared a question. I have to change the sense of that question because I want to ask you, how do you see the future in liver transplantation? Because, of course, overall survival has overcome. We have already know everything about immunosuppression. So the indications of liver transplantation are there. But after your talk, maybe the problem is that there is quite a lot of people who died because they don't could be transplanted, maybe in low-income countries. And the traffic donor is just crazy because it's real, it's a reality that is there. And maybe nobody talk about that. So maybe the future liver transplantation is there, no? We have to overcome these barriers, no? What do you say?
So the future of liver transplant, in part, is going to be answered by the technical advances that are happening right now that are so exciting. I don't know if you are all trained in robotic work, but you should all be trained in robotic work because that's the future. Live donor donation, live liver donation will be done robotically, just like live kidney donation. That's the future. We will need xenotransplants because we don't have enough organs to go around. We need to police one another to make sure that people are doing transplants in an ethical fashion. I mean, this trafficking thing is crazy. You're right. It's terrible. You are right. We understand the immunosuppression. You are right. We understand the need. We have to get enough organs, whether they're printed or xeno or live donor, but live donor done in a different way. We need to minimize the injury and the risk to the donors, and we need to stop trafficking.
Yes,
but so I didn't tell you, in Nepal, in low-income countries, you have to start not when patients are at end-stage renal disease, for example. You have to start when patients are hypertensive or when they've got proteinuria. Now, I know you're surgeons and you're not worrying about this stuff, but you have to worry about, these global health issues. So they did a little pilot study in Nepal where they used just a really simple, 2 antihypertensives for patients with proteinuria and with hypertension. And they were able, over a 5-year period, to prevent the progression of renal insufficiency. So we have to do that. For liver, we've got to fight NASH. We've got to change the habits and the diet and the exercise routine of people. We've got to stop alcohol. I'm sorry to tell you all. I don't know what you like to do. I remember when I was young, but the truth is that we've got to really think about these diseases that are so harmful for giant swaths of our population. And liver cancer only occurs on the background of cirrhosis, pretty much. So something's going on with your patients if you are surgical oncologists. I think the future of liver transplant also is much more aligned to surgical oncology now. So cholangiocarcinoma is now an indication for transplant, hepatocellular carcinoma. Some of the sarcomas are indications for transplant. No, we're really moving toward that. But we have to have enough organs.
Yeah, you're right. So just one question, because you're female, your leadership is unquestionable. So how did you deal with the others who questioning your role or your decisions? For sure, you maybe faced with this kind of maybe mates or whatever that are questioning your role or what you decide or your techniques or whatever.
I ignored them. I pretty much ignored them. You got to do that. And you need the community. You need other like-minded people, whether they're women or men. You need people who kind of get it with you, because then you're stronger. But I pretty much ignored the people who said you can't do it. In fact, that's what I always wanted to do, what they said I couldn't do. The monsters. What they said I couldn't do is what I wanted to do. There was just something that made me want to do it. So celebrate it. I ignored them. I wouldn't wear scrub dresses. I wore scrubs, you guys all wear scrub pants and shirts. But when I was growing up, they were dresses for women. It was so stupid. It was so incredible.
Wow.
So I just put on the scrub pants. I just ignored them all.
Wow. And what do you recommend for those who wants to be liver transplant surgeons or transplant surgeons, kidney, or what do you recommend them?
What do you mean, what do I recommend? I recommend you do it.
Okay.
You do it.
How hard it is, yeah. But
it's not that,
hard,
it's an okay life. The issue is if you commit to caring for patients, if you commit to your work, whatever you do is going to be hard. It's a commitment. It's it's from inside, it's what you want to do. You've got to decide that you want to do it. But you've got to, you shouldn't do it if you don't get satisfaction from it. You shouldn't do it if it doesn't resonate with you. But if it resonates with you, do it. Just do it. Sorry.
Completely right. Completely right.
So, Dr. Ascher, what is your
Yeah.
motto?
What?
What is your I don't know how to say it in English, your motto.
I want
your
more
motto.
from you. I want more from you. You can do it. That's my motto. I think you can do it. You know, my kids, when they saw the Netflix, they laughed. I mean, because you can imagine it's bad enough to hear me like this. You can imagine if I was your mother. So I mean, I really feel like if I can do it, you can do it. You can do it.
Yeah, it's a very strong message for sure.
Yeah.
There is any questions on the chat?
So you can email me if you have questions. You can, if you want a pen pal, if you want somebody to, you know, push you, to prod you, I can do it. Yeah.
Dr. Paul Itula, a general surgeon from Tanzania. They are hosting first liver cancer conference in Tanzania from 17 to 18 this week. It's possible to be in touch with Dr. Nancy Ascher. Thank you. I don't know. Dr. Ascher, they want to be in touch with you.
He wants to get in touch with you. He wants to
get in touch. Email me, nancy.ascher, ASCHER, at UCSF.edu. I'll answer you. But introduce yourself so I don't think you're a cuckoo.
For sure. So you're operating right now, Dr. Ascher? You are doing in the hospital regular things, you are, or just professor in the university? You are still operating?
Yes, I'm still operating. Still operating.
Wow. Wow, amazing.
Yeah, that's
Dr.
where I live.
How is it to live with a surgeon?
What?
How is it to live with a surgeon?
To live with a surgeon? You're asking me? My husband is a surgeon. Maybe you should ask him what it's like to live with a surgeon. I think he finds it challenging. So, you know, I believe in, you know, this fairness thing. So you may have heard from Netflix. We have 2 kids. So we had one child who we named Ascher Roberts, because I wanted to be the senior author. I mean, Roberts Ascher. We had another child that we named him Ascher Roberts. He was the senior author. So, I mean, you know, I believe in equality.
Good.
Anyway.
David and the Young wants to, yeah. One question from David and the Young. How hard is to get into abdominal transplantation fellowship as foreigner in USA?
So this year we had, for our program, so there's like 69 programs in the United States, training programs. And this year we had 50 applications, 10 of whom were people who graduated from other countries. And we looked at them all. And the colleagues from other programs also looked at, I believe, looked at everybody. So I think you can get in there. The truth is, if we're going to meet the needs of the people in the world, we need many more transplant surgeons. Our workforce is sorely lacking. So I think you're going to see a change in the next 5 to 10 years about the number of people that we need. And people are starting to recognize this. In addition, don't ask me about the United States, because the advances in liver transplant at the moment are not in the United States. They are in India. They're different places. They're in Turkey. They're in South America. So you can train in the United States, and that's great. But there are other places that have stuff to teach you that's fantastic. And I want you all to think about that. You know, I'm not standing here from a position of, you know, I've got it all. There are other places you should really think about. Sorry, I'm so.
No, right. It's a great message. We enjoy. Yeah, someone is sharing your email because maybe they didn't understand well. So Maria,
Nancy.Ascher, it's spelled right up there, at UCSF.edu.
I think it was quite clear, Dr.
Okay.
Ascher. I don't know if there is any more questions, John, if there is any questions from you. I enjoyed really the talk today. It's
Thank you. It's
amazing.
really nice to interact with you.
I think that John has already gone because I think he's on call. But that's it. Maria, if you want to say something, Dr. Ascher, many thanks for your speech. It was very inspirative. So thanks a lot.
Sure.
Yep, thank you everyone. And then you can always check for the upcoming webinars on our website of soweb.org in the courses. Yeah.
Thanks
Thank you,
a lot.
Cristina.
Thank you.
Have a
Bye,
nice
everybody.
evening. Bye. Bye.
Bye. Oh, John. Let's just wait to say bye to John. Hi, John.
Yeah, you are on call, I believe. John?
Sorry, well, yeah, bad connection here. Just to thank Dr. Ascher for her impressive presentation. And I hope you enjoyed it as much as I did.
Thank you.
Yeah, thank you. Thank you, everyone.
Bye. Bye.